Okay, thank you so much to everyone who has joined us for this session. My name is Hannah Arem, and I'll be moderating today. See some familiar faces in the audience or names, some new names or faces. Please feel free to turn your camera on if you'd like, especially during discussion, or leave it off if you're more comfortable. We'll be talking today about creating sustainable infrastructure to support cancer survivors by identifying and addressing social risk factors and reducing health inequities. We have a fantastic panel. You're not really here to hear me speak. Our panel includes Lisa Sims Booth, who is the Executive Director of Smith Center for Healing and the Arts, the only nonprofit organization providing whole person innovative health services in Washington, D.C. And Smith Center is especially known for its work meeting the unique needs of people with cancer. We also have Owulabukola, also known as Buki, who's a community health worker with MedStar Health Research Institute. She works across multiple research projects to identify and address cancer survivors' social risk factors and to support patients in care coordination. She has a master's degree in public health, and prior to coming to MedStar, she previously worked with a community-based organization to lessen the burden of cancer on African immigrant women and their families. We also have Tallulah Anderson. She is the founder and CEO of 2 for 2 Boobs, a grassroots community-based organization located in Maryland. She is a 3-time breast cancer survivor and chief thriver advocate, which she can tell us more about. 2 for 2 Boobs was founded as an organization dedicated to not just provide awareness, but action to do monthly self-breast checks with a mission to educate, engage, and empower both women and men to be proactive in knowing breast cancer risks, genetic testing, and how knowing family cancer history can allow for better health outcomes. Jacqueline Beale is a 19-year breast cancer survivor dedicated to ensuring access to adequate, affordable, and integrated healthcare for all and eliminating health disparities. She's a national ambassador, advocate, and founder of C2JB Consulting, which is an organization dedicated to promoting health education and advocacy. Both Tallulah and Jacqueline are participant advisory board members on the CDC project that we'll be talking about today, CDC funded project, I should say, which we'll be talking about today to address health inequities for cancer survivors. So before we start, we have, as you've seen in other sessions, agreements for a safe and brave meeting. And I'm going to borrow an example from the previous session that I was in, where the moderator highlighted just one of these principles that particularly stands out to that individual. But I also encourage everyone in the room to go ahead and point to one. If you want, type one in the chat if there's one in particular that speaks to you. Although, of course, even if just one is being kind of highlighted right now, we hope and expect that all participants will adhere to all of these principles. So I'm going to highlight welcoming being called in as a gift and an invitation to learn, and hope that we can all participate in the session and take some gifts away from this and learn from our presenters today. Ways to engage the room. Please do use the chat. I'll be monitoring that. Again, if you keep your camera on, we'll be able to see your responses. You can unmute to speak. If you have any questions or comments, there are also options to use emojis. And of course, if you use social media, here are some tags that you can use during the session or after the session. So this session stemmed from previously, as I mentioned, a CDC funded project where we are aiming to improve cancer survivor health and well-being through addressing structural inequities and racism. And within that, there are 3 major components. One is to improve clinical community linkages. One is to employ community health workers to facilitate connections between healthcare settings and community supports. And another that goes across all aspects of this work is to deliver anti-racism training and measure the impact of that within and across healthcare settings. So what we're going to be talking about today is not so much the specifics of the research findings, but rather the experiences that our panel today has had in that area of addressing structural inequities and racism, and how that ties into this project and other research initiatives. To frame the work that we're doing, we decided to employ the R4P framework, which is a health equity framework for research planning and evaluation in African American populations. This is a framework that was suggested by one of our co-investigators, Dr. Miranda Ward, and we felt like really nicely frames some of what we want to talk about today. The first R in R4P is remove, or intentionally looking for where racism can show up in the research design or intervention. The second R is repair, considering past injustices and trauma caused by research within the target audience to repair the damage done to university-community partnership and regain trust by community members in research. Restructure, analyzing the research and participant advisory board structures to assess how to restructure policies, expectations, or traditions that will further marginalize historically excluded groups. Remediate, lowering the inconveniences or risks associated with research structures and processes, and providing capability building, capacity building, and or resources in ways that are accessible and equitable. So I'm going to go ahead and stop sharing my slides so that you can see our speakers and that we can start to get into some of this work. So I'm going to start with remove, or intentionally looking for where racism can show up in the research design or intervention, and ask our speaker, Lisa, to start by sharing an example of how racism and discrimination and social services are providing to cancer survivors is something that she has observed.
Thank you so much, Hannah, and thank you all. So nice to be with you today. And you know, in our experience at Smith Center here in DC, we find the work that we're doing is around whole person care, and we're really focused on providing that emotional, psychosocial support for people as they go through their cancer journey, as well as their family. And so what we find is that because of assumptions made by some providers, they don't even bring that kind of support up to people, you know, based on what they're seeing as they, you know, just how they look, or what their economic status may be, that they don't even bring up that perhaps you'd be interested in supportive support group or that kind of thing. And so when people find us, it was like some roundabout way and not directly coming from the provider. So again, that kind of thing is just made based on assumptions. We also find that people want to focus everybody on logistical issues of their, you know, can you get to, you know, you have transportation, do you have this, do you have that? And sometimes not even asking about their emotional well-being altogether. It's like they're not a real person. They're just looking, they're just making, again, that assumption. And then ours, you know, in our perspective, you know, when someone's just gotten a cancer diagnosis, you know, their whole world has been upended, and we should be, of course, asking about their overall well-being. Another way that we see this play out as well is for especially some of our young women, is that they're not told about the opportunity to freeze their eggs or do any kind of fertility preservation at all. You know, typically because there's the assumption they can't afford to do that or something like that. So again, making blanket assumptions and not just providing that information that could be very desperately needed. And often they don't find out that that was an option until it's perhaps too late, you know, because they've already started treatment and things like that. So we really see that sometimes vital, like nourishing, supportive information is not shared just because someone's made a blanket assumption based on the appearance of race or ethnicity or financial issues. And we really, and this is something that, you know, we have definitely heard and seen. And that's why work like this and conferences like this are so important. I'll also give one more basic one, which should be fairly easy to assess, and I'm sure you've heard this one as well, is the opportunity to have proper language support for people that might need translation. And so entrusting the family member, you know, who does speak, you know, be able to translate, but that family member is being put in a horrible situation of translating medical hard information to their family member when they're having a hard time processing it themselves. And so again, just putting the family, the patient in a really tough situation by not assessing what the real needs are and not taking that extra step in providing that kind of care and support. And so those are just some of the examples that we've heard about, we've seen people. And then, then of course, as many of you probably do in your work or heard about, then we have to repair that damage on top of what they're already going through because they have a cancer diagnosis. And so, and I know in our work at Smith Center, we just want to make the process, we want to make the journey, whatever it looks like, as easy as possible, not harder, but sometimes odds are already stacked against because of some of those things that have happened prior to them coming through our doors and getting involved with our support groups and things like that. So I look forward to hearing from my cohorts on the panel. I know we had our little check-in call the other day and we got some really good information, but those are some of the ways that we see these really blanket assumptions causing real harm. So thanks so much.
Thank you, Lisa. You also provided a perfect segue into our next topic, which is repair, considering past injustices and trauma caused by research with our intended target audience, and repairing damage done to university community partnerships to ultimately regain trust by community members and research. So next, Tallulah, given your experience both with community-based organizations and as a patient, what do you suggest to researchers and academic organizations to address power dynamics that lead to mistrust or barriers to engaging in research?
Good evening, everyone. Good afternoon, everyone. Mentioned before, I am a 3-time breast cancer survivor. I call myself survivor to thriver. It's been over 23 years from my first diagnosis to many treatments, being cancer-free since 2014. And I've been the founder of my nonprofit now for over 12 years. And as a patient advocate and a small grassroots community-based organization, I am happy to share my experience and some of those communicated to me by other advocates and CBOs. We have relationship issues, damaged by lack of trust because we often feel, just as the communities where we live and work, with a bad taste in our mouth, from bad history, to not being understood, being undervalued, overlooked, not communicated to correctly, and basically just not invited to participate. And that leaves us with some trauma and, afraid and feeling like no one really cares. And when they do care, it's only for those bigger with more money or, say they can bring in the community members, but in essence, they're reaching out to us and we're doing the work, but we don't even get acknowledged. That, for me, has left a bad taste in my mouth, as well as an advocate and a survivor for, my experience is not even being invited to participate in a trial until maybe last year. So that's like over 12 years. And I've never seen anyone come in my community and ask for anyone to be in a trial. And if they did, would I trust them? Probably not. To the community here, trust them? No. However, we bring value because they trust us. And if we show trust in those researchers who come into our communities, they're more likely to participate. We all saw that during COVID, right? The vaccine was scary for a lot of folks. Because of past histories centered around things like the Tuskegee experiment or just some myths about if you, everything from becoming a zombie, etc. But when it was realized to use community influencers, doctors, business people, even professionals and actresses and people that look like the people in my neighborhood who look like me, then it was trust. For me, I was one of those people that sat on the fence. I was like, I'm not going to get vaccinated until I see everyone else and see what happens to them. However, what made me move was seeing my physician get vaccinated. And when I saw that, I said to myself, I can trust this physician who was my breast surgeon to, operate on me and, remove my cancer. And if I could go through the treatments that I went through, then I can go and get vaccinated. So that built my trust up. Also, the barriers, there are many barriers to overcome, but I think they can be overcome by building those relationships, listening to our perspectives, inviting us to have a seat at the design. And look, some of us will, even if there's not a seat, we will stand just to be a part, right? To strategically plan with us, collaborate with us. And if you are going to support bigger organizations, mandate that they outreach and include smaller organizations and not just one. There's different, there's power in numbers, right? And even across region. And within the cities and communities that we serve, we could bring more people into what you're trying to do. So with that, I want to say that we want to be empowered. We want you to spend time with us. We want you to come into our communities, support our communities, invest back into our communities. Let us see you doing the work and being interested in what we do. Most importantly, collaborate, partner, compensate, recognize, and acknowledge our value as patient advocates and grassroots CBOs. Thank you.
Thank you so much, Tallulah. I was taking a lot of notes, and we're going to come back to a lot of this in our discussion. That was a fantastic response. We are going to move on to restructure and talk about how researchers and participant advisory board members can critically analyze both the research and the participant advisory board structures to assess how we should restructure policies, expectations, traditions that might marginalize historically excluded groups. So let's turn to Jacqueline and ask, one of the goals of our work is to restructure these research expectations or traditional practices to better serve historically marginalized groups. For this study, how can social needs screening and community health worker engagement empower individuals from historically marginalized groups?
Thank you, Hannah, and everyone, and to my colleagues on this panel and for this conference. I think it's extremely valuable and important that we have these discussions. And I like that we're already being transparent about having them. So I appreciate that. But I'm going to talk about a lived experience, and then I'll directly address your question. And so I want to share, I remember when I was going through treatment, Hannah mentioned that I'm almost a 20-year breast cancer survivor, but I remember going to a pharmacy to pick up my prescription for nausea medicine to aid with combating chemotherapy side effects. And the pharmacy was located in a suburban area, absent any people of color working there, at least on this particular visit. And the location was predominantly settled by white people, just like the hospital and physician offices near it. And I know this because I was a patient in the area, albeit I didn't live in that city. Just so happened that my doctors and the hospital were there. And there was this Black woman in front of me in line who was attempting to get a prescription filled. And the person in the pharmacy didn't exude any caution to be discreet when speaking to the woman. So I could hear the conversation. And the woman did not live nor work in the area. And she, was in a hurry because Metro Access was on its way. And the woman had a strong accent, and if I had to guess or venture to say, maybe of African descent, which was obviously a challenge for the pharmacy employee because she kept saying to the woman, "I don't understand what you're saying." And so the woman was a cancer survivor undergoing treatment and attempting to get her medication. And the woman's insurance did not cover the prescription costs. And I remember the pharmacy employee saying, and I'm quoting, "Well, I don't know what to tell you or what you can do." And I thought to myself, that was abrasive and insensitive. And by this time, the woman was in tears naturally. And the pharmacy employee said again, and I'll quote, "Can you step aside while you try and figure this out? Perhaps give the doctor's office a call or a family member who can loan you the money." And so I kindly told the person behind me to go ahead, because me and my inquisitive self, I wanted to have a conversation with the woman who was in tears. And so I walked over to her and she shared that the cost for her prescription was $1,500 and her insurance didn't cover it. So when I got to the counter, I asked the pharmacy employee, was the lady being offered a generic version of the prescription, and if there were any assistance available through programs that perhaps she was aware of to help this woman. And, now I think about it, it was a really dumb question, because I was in a predominantly, white, middle, upper class neighborhood, and the customers probably didn't need programs. And she responded, "Excuse me." At that point, I just decided to forego any further inquiry. So when it was my time for me to pay for my medication, the pharmacy employee said, "Oh," and I'm quoting, "you must have a good job and good insurance, because you only need to pay $10 for the same prescription medication that woman needs." And I was livid. Her comment was inappropriate, but it wasn't inaccurate. I did have excellent insurance and I did have a great job. And I also noticed how she interacted with me versus how she did with the woman who could not afford her medication. I was called Miss Beale. The woman was called ma'am. I was continually engaged with a warm smile. And while I observed when the pharmacy employee conversed with the woman, there wasn't a smile and it didn't appear to be any empathy. And so, I was handed my medication and told, stay well and keep fighting, and, and to have a nice day. So by this time, there were no other people in line. So the pharmacy employee asked the woman, "Did you figure something out?" And so the woman, of course, turned and walked away. And I remember thinking, I don't know if the pharmacy employee was racist, but there was some implicit or unconscious bias going on. The woman was Black. She didn't live or work in the area, didn't have transportation, and underinsured. And I walked away thinking this interaction would have been different if it were a white person. And this was my introduction to health disparities and why I advocate for access to affordable and adequate healthcare protections for all cancer patients and survivors through, legislation, and champion health equity especially for Black people. And the experience forced me to look through a different lens and motivated me to fight for others whose social determinants of health are impacting their quality of care. And this woman seemed to sort of, if you will, check the box for all of them. And so I believe this concept of social needs screening would have addressed this issue. And through patient engagement, ascertaining any needs through an assessment or intake may have revealed some of the barriers that the woman had. And this could have led to discussions about programs, assistance, less expensive medications, alternatives to using the prescribed medication, if any, or just having a conversation with her doctor or finding out other healthcare options. And I believe the community health workers partnering with patients would have likely lent itself to, obtaining this information and a different outcome. I think back and it breaks my heart because we left, and I'll use the generic we left this woman humiliated. We left her continually unwell. We left her unsupported. We left her without resources, and we left her leaving that pharmacy not knowing what her next step should be. And so I just think, if the community health workers can partner with these patients, then the patients, this woman, can become more actively engaged and participate in her own healthcare, and she can get assistance or aid in advance. And so I'm always saying, you don't know what you don't know. And engaging patients to identify social needs in the beginning and include them in decision-making will empower them to make the best decisions for themselves. So addressing social needs through research has to be complemented with education. And, you know, I keep saying the we, and I mean, we all overall, but again, we did a disservice to this woman. And so I echo my colleague on this panel, Lisa, when she used the word harm. We contributed to harming this woman, and we didn't do anything. So continued research through education, well, with education, I think will help us get to a different state. And thank you for allowing me the time to speak.
Thank you so much, Jacqueline. That's an extremely powerful story that I think there are a lot of lessons to be learned. We'll move on to remediate, the last R. This step coincides with restructuring, the previous goal, to help lower or remediate inconveniences or risks associated with changing research structures and processes. So we'll have Buki, the community health worker, one of the community health workers on this project, tell us about adapting delivery of social needs screening processes to accommodate patient preferences and needs, and balancing that with clinical workflow.
Hi, everyone. Thank you for the opportunity to be in this conference and to be able to speak with regards to how I deliver screenings to patients. So the key to delivering screening to patients is meeting them where they are at. And majorly, we deliver screening. We meet patients at their appointment to try to catch them at their appointments. The space between when they are triaged and when their doctor comes in, we have collaborated with the clinics, and we're, once the MA is done with, triaging them, I go into there and do the screening. Of course, we know that sometimes, depending on the needs, that time is not enough. So there's always the opportunity to call the patient right after, like later that day or later that week, depending on what the patient prefers. We also leave our business cards for the patient to reach out to us, so we are able to deliver the screenings and also, provide resources for the patients or whatever support they may need. And honestly, it's been a very good one, because I've had patients call me right after their appointments, or even when their doctor was not there, because maybe when I was there, the doctor was there, to open up about some of the resources or some of the support they needed, and it's been so impactful. Another way we deliver screenings is through phone calls, and some patients, we can't reach them at their appointments. So also, like I said earlier, we collaborated with the clinics, and they would have been pre-informed about that a community health worker was going to reach out to them to ask them questions about social needs. So we give them the call. That way they are aware that we're going to call them, and we ask the questions, ask them questions about social needs, and see if we can potentially refer them to resources. And sometimes we also do home visits and meet patients at the community if we are not able to meet them at the hospital or catch them over the phone. And if they prefer, we have the option to also see them in the community or in their home to deliver screenings, and also introduce them to any of our studies that we do. I do have a particular story that stood out to me. I once went to see a patient at the home, and I was trying to, I'd done the screenings. She had just some needs, and I was trying to get her into one of our research studies, which actually the CDC study, which is majorly about social determinants of health. And I remember trying to enroll the patient, and once she heard what's research, she was like, nope, I'm not interested. She's an elderly lady, African American, and she was like, no, the word research, I'm sure caused the triggered something in her. And I took my time. I told her no pressure. I explained the purpose of the research and the impact, and why it's important that she she participates if she wants to. I remember at the end of the conversation that day, she was more than willing to be in the study. And, it kind of reiterates what Jacqueline mentioned about the function of community health workers. So she was like, okay, I'm just going to wait for my daughter to come home and read this, but trust me, I'm going to call you. I'm ready to be in this study. So that was a very good one for me. And it also made me realize the importance of sometimes knowing the right terms, how to explain these things to patients, how to just be there to be of support, whether or not they want to be in the study. So that was a very good one. So the next time I went to her house, it was just straightforward. I enrolled her in the study, and she's one of my patients. And also, we don't only give resources to patients that are in the study. If a patient chooses not to be in the study, they are still connected to resources, and they still get the support that they need from community health workers. So these are some of the ways that we deliver, screenings to patients, just to accommodate their preferences. Thank you.
Thank you so much, Buki. Appreciate your thoughts and the story you shared with us. We're going to open the floor up now on Provide, both to our speakers as well as to any audience members who want to participate. I don't see anything in the chat, but please do feel free to use the chat if you don't want to unmute and speak. But for Provide, we are reflecting on capacity building and resources that are embedded within the research, and if they're provided in a way that's accessible and equitable. So thinking forward, how can we build accessible and equitable programs to support cancer patients and the community? And one of the big goals as well in this project is sustainability. So how can we create sustainable programs, relationships that will endure not just for the next 4 years of this specific funded project, but will be able to sustain themselves after the end of this research. So one of the things that jumped out at me, for instance, in Tallulah, in your response, was some of the suggestions you gave at the end of your story and thoughts, suggesting that individuals, researchers need to do the work, really show an interest in what community members or CBOs are doing, compensate participation, partner in a way that serves both sides. Are there any particular examples or ways you've seen this done well that you might suggest that have endured over the years?
Actually, yes. And two other things that I didn't mention is, and it goes towards what you just asked about sustainability. It's investing in training and educating some of the CBOs around the research so that we're better able to voice and communicate. And when we're at the table, it gives different perspectives, right? And you're going to give us what we need, except for what you think we need. And, a big part of that would be helping to co-develop some metrics to examine the outcomes from any partnerships that helps us for increased funding. So an example of that for me would be recently being outreach to help with a trial where they were looking to see if they could collect some specimen like fingerprint and some saliva to test for genetic testing. And they reached out, they trained on the subject matter. They also asked questions about the community where I lived, about those who are part of my network, who would probably be involved, some of the potential questions and concerns that they may have. And they wanted to partner, and they acknowledged our value because we brought quite a bit of participants, more than they expected. And they also compensated us. They included us in their, actually, when they were putting in for the grant, they included us. They made sure that we were a big part of ensuring that they could accomplish their goals. Hello?
Thank you. Yeah. Thank you. We heard that. I was digesting it and thinking through that. Lisa, Jacqueline, do you have anything to add, either from CBO perspective or patients that you've observed?
Yeah, I love what Tallulah shared just now and before. I think the most important thing is really engaging the patients, or I don't even hate to even call them patients, but people who are dealing with cancer. They want to be involved here. They want to contribute, but you can't treat them like an afterthought in the process. And I think that's what's happened. And then you get into some of these situations where, especially working with community-based organizations, where people come around asking for your help, but then they don't give you the due credit that you deserve for the compensation, as Tallulah mentioned, or then as soon as the grant funding is gone, they disappear. And so I think that there has to be long-lasting commitment to that organization and to those people, and really to build the trust that was mentioned earlier. It is come down to trust. And if you don't feel like there's that trust, or that you're really being valued and your contribution matters, then you can't, and who would want to do that? Like, why would you participate? And so I just think that it's important that we approach this research, like really stressing the need to just honor the commitment that's being made. We're asking a lot of these people to give of their, and we're asking a lot, and they need to be met back with the same level of respect and understanding in the process. So those are just, because I've seen when it goes bad, and it's bad, and there are a lot of really hurt feelings. And again, we go back to the harm we keep mentioning. There's so many ways to do harm, but we have so many opportunities to get it right. It just may take a little bit of extra work to do it.
I think that the word that we all are using is engagement. And I think if we take the time out to be mindful of what engagement is, because I think sometimes we use it loosely, but if we're mindful of what engagement is, and then we are just as mindful of how that engagement looks and how it should feel based on the partnerships, not just based on this generic, sort of processes we've put in place or that have been in place for some time, or what we believe, again, what engagement is. But if we are mindful, because it'll look different all the time, and it's not a one-stop shop. And so I think if we take time out in the beginning to make sure that we address that, I think we can, as Lisa said, and we could probably get it right sooner rather than later.
And the most important thing for me is letting our voices be heard and actually listen, meaning, okay, we spoke, we communicated. Don't just walk away. Let's see some action behind it. And I mentioned compensation. Sometimes that's not that important, right? Sometimes it's just like I have mentioned before, the acknowledgement, because we want to be a part of saving lives. We, as a advocate, survivor, thriver, I started my nonprofit because I wanted to save or educate my family members. I have genetic breast cancer. My mom had breast cancer and my dad had breast cancer. So for me, it was making sure that my family members got educated about doing self-breast checks, genetic testing, and it was also about me educating my community. I was very passionate about it. For me, that was my goal, to connect people to resources, information. I still do that today. It's not about being the biggest and baddest. For me, it was about how many people can I educate and connect and get genetically tested and really understand the importance of early detection, because I'm a 3-timer, and all 3 times I found my breast cancer, and that was because I knew my normal. So for me, again, it's let my voice be heard, acknowledge that you listened, come let us see you, build the trust with us so we can build the trust of the community. It's an easy roadmap to follow. So we just need to, like Jacqueline said, be mindful and just make it happen.
I think that echoes a lot of what we heard in our formal interview processes that we did both with patients and with community-based organizations to understand what people wanted, how they wanted to interact with clinical staff, how they wanted to discuss social needs with their medical team or not. And we found for the most part they did, but it was based on a conversation and not just like, say, a form to fill out. And I know Buki has shared some stories about how that's manifested on an individual level when she's first approached someone, and who's around and what the setting is and what people are willing to share in different settings. I see Alejandra, you have a hand up.
Yes. Hi, everybody. Thank you so much for these wonderful talks. Very inspiring. So I have a question. So as a researcher, I think like sometimes some research is very, they prioritize the rigor, and like sometimes then like people are not eligible. And I think it is key as researchers to be sure that we are doing research that makes sense for the community and that we can adapt and be flexible to change, that we make sure that we are meeting the needs, and it's like a bi-directional relationship. And I struggle with the sustainability too, because like we have these grants and then they finish, but we want to make sure that the effort can be sustained. And also I think as researchers, we need to educate ourselves better on how to engage more in the advocacy piece, because we might not have the training or like the expertise, to do the advocacy, and which some of the organizations are the experts on that. And I would like to know, like, how can we better understand the world of advocacy and like see how we can take these collaborative efforts further so that then it doesn't end when a grant ends. I don't know if anybody has any thoughts or suggestions.
So I'll start as an advocate. I think one of the things that we do is we forget that advocacy doesn't end. And I think that we have these grants and we focus on the beginning and end date of them, and we do the same. We have the same parameters for advocacy. And when they're over, we feel like we have done what we needed to do, and we may have, but we haven't done, there's still more to do. And I think there needs to be, at the end of these grants, some thought put into, okay, we've completed the grant, but what do we need to layer onto it now through advocacy? And I think that's where we miss a step, because we've engaged, I will say, participants, if you will, but after the grant, then what have we said to them? What have we done with them? Have we even circled back around with them? Have we let them know, how their participation will help? Have we let them know how their participation will move the dial on cancer research? Have we let them know that their participation was beneficial because of XYZ? I don't think we do that, and therefore I think we leave out the advocacy component in research, because we think advocacy is over when we finish the grant, and advocacy never ends, especially, and I'm speaking through the lens of a cancer patient and an advocate and have partnered with organizations in doing research. And I think we have to figure out the next step when the grant ends.
I so agree with that, Jacqueline. You know, there is that next step, and Alejandra, it's a great question. What do we, you know, you've got these, everyone's engaged and the researchers are engaged right, as well, right? And so what do we do now with that? And so I think you're absolutely right that there needs to be, you know, do you want to continue? Do you want to help? Do you want to help educate others? Like, what do you feel like the next question is? I think the wonderful question would be to those participants, do you want to, would you want to stay engaged in some way? And then if they do, can we connect them to, you know, what's the next, is there another organization that's doing the same work that you could get them connected to? I mean, I think there is a next step there. And I think the same for the researchers in letting them connect somewhere else. So I think it is just asking those additional questions. So if you get people that want to be engaged, you know, there's nothing better than that. Like, you know, your work in Tallulah, there's nothing better, and Buki as well. There's nothing better than somebody who's like, what more can I do? So then where can we take them? You know, maybe they become a community health worker, you know, maybe they become a patient navigator, or like you know, there are options, and people that have lived the experience going on with the work, that's really powerful. And then they can speak because they've lived it too, and they can reach so many people. It could reach so many people that way. So I think it's a great point, Jacqueline, to how do we follow up on that?
I'll add, and it could go towards bringing more people of color into the research field, because there's interest, right? And we as advocates and CBOs can help with recruitment and, you know, work with schools, you know, have you come in and speak about what you do. There's so many different opportunities that are wasted.
I think I agree with everything that you've said, because, you know, sometimes when in trying to get people into the study, sometimes it's only maybe one or two people that have actually said they want to be in the study because they want to help other people. You know, a lot of people don't really know what they're going to get out of the study. It's 6 months, it's over. Thank you for your time. We give you a compensation, but how does it continue? And I like the point of, you know, giving them opportunity to engage or be an, you know, an advocate for other people. That way they encourage people that, see, I've been in this, I went through it, and it's going to be good for you as well. So those are really good points that you raised.
It makes me think too about the so many different levels you can engage people on. You can engage the patient, you can engage the advocate, you can engage the CBO, you can, you know, one of the things within this project for us is trying to engage our healthcare system and say, how can we, you know, get you guys to recognize what's going on here, and then think about how this program could be integrated into actual practice and not be, you know, separated or siloed on the side. I want to thank everyone for attending. I know we were asked to end on time to allow for the reflection session. I do want to share my screen for one final moment to acknowledge our funders. Hopefully this is showing up for everyone. And I think, again, my screens have switched, but hopefully you can see our funders here, our study team. This is only a fraction of the team. This is truly a team effort. So thank you to everyone who has contributed to this work. Thank you to the participants, and we hope to continue the conversation. We're very honored to be able to present today.
Thank you.